Buonasera, buonasera a tutti, è sempre un'emozione per me aprire per l'ennesima volta una puntata di Shoulder Channel, benvenuti a Roma e oggi è una giornata particolare perché abbiamo degli ospiti di onore. L'argomento della giornata sarà un osso particolare ma estremamente importante e quanto complicato da studiare, che è la scapola. Mi viene da dire che dietro la scapola c'è un mondo che abbiamo in parte scoperto, ma
which we have partially uncovered, but the gut feeling is that there is quite a lot to be discovered about the scapula. Tonight, we're going to listen to eminent international personalities who are devoting their lives to studying the scapulothoracic joint and the shoulder in general. But I'm going to give Elena Silvestri the honor of introducing our guests. It's really an emotional experience tonight because we're going to talk about a joint for which we have developed passion, which is also important in terms of rehabilitation and of our everyday work. And tonight we have two friends with us who have been working with us, who have helped us to better understand this joint. We have Ben Kibler live from Lexington, Kentucky, 40 years of experience devoted to the study of the shoulder joint. For many years, he has been the head of the Shoulder Center of Kentucky, the founder of the Shoulder Center in Kentucky, and he has helped us over the years to study and to fall in love with this joint that even today is the source of many questions. Thank you very much for being with us. It's an honor and a pleasure. Good evening.
Good evening.
And then another long-term friend, Todd Ellenbecker, physiotherapist, is going to help us better understand what is the role of rehabilitation therapy in the framework of the world of the scapula. Vice President of the Medical Service of ATP, so many years of experience, more than 15 books and 75 chapters of books published, 55 scientific articles published. You really are an icon for us, a guide. And as soon as I can, I ask him many questions. Thank you very much for being with us.
Arriverà poi in collegamento con noi.
Later on, Bassem El Hassan will join us. He's in the operating room now. He will join us later on from the Harvard University. We will introduce him to you later on. He's a brilliant surgeon, formerly at the Mayo Clinic. He has an enormous experience from the surgical viewpoint of this complex joint. He has worked in the surgical treatment of the complexity of the shoulder joint, and he will join us later on in order to discuss together what could be the approach to the scapulothoracic joint. Enough said. Now, I'd like to give you the floor to start with the introductory presentation. Yes, this will be just my brief introduction, scientific and historical introduction about my relationship, so to speak, with this particular bone that is the scapula. This is the scapula. As you can see, it's a flat bone, which of course has different characteristics. It is a bone with many different functions, and I'm sure that in particular Ben Kibler will explain to us what are the biomechanical functions of this bone. This is the glenohumeral joint seen from the front. Now let's have a look at the history. I've always been fascinated with the shoulder, thanks to Ben Kibler. When I worked in Kentucky with him, we very frequently talked about the most frequent pathology that is the subject of much discussion, that is the lesion of the rotator cuff tear. And, you know, many patients owe to Ben Kibler the fact that they've not undergone surgery, because thanks to him and to Steve Burkhardt, knowing full well the functional anatomy, the biomechanics, not just of the glenohumeral joint, but also of the shoulder as a whole, and in particular of the acromion-clavicular, sternoclavicular, and scapulothoracic joint, we have finally understood that by improving the biomechanics, by improving the kinetic chain of which the shoulder is a ring, it is possible to improve the clinical condition of many patients without surgery. So this was, I was lucky. I was lucky because many years ago, my friend Ben Kibler helped me to understand that, and even today, when I can, in some groups of patients, we do that. A key word in the shoulder pathology is patient selection. I've learned as much as possible to correctly select the patients that deserve a conservative treatment and from the ones that need to be treated surgically. And sometimes it's not so easy to understand the difference between the two. When we speak about the scapula, biomechanics is important. There is a scapulothoracic glenohumeral rhythm or pace. Of course, the glenohumeral joint plays a role in the movement of the scapula. We might describe the scapula as a flat bone. The medial margin runs parallel to the first thoracic vertebrae, but also the very complex movements at all levels of the scapula, which then lead to the retraction and protraction movements, are a very important topic for study and research by many groups throughout the world. And then all these very interesting muscles play a role because sometimes the rotator cuff seems to be more important, but the muscles there are not less important. The levator scapula, the lower trapezius, the lower rhomboid, and many other very interesting muscles which drive the scapula around the chest, in particular in its relationship with the proximal third of the humerus. Rather than watching videos, we prefer to study on the specimen what the anatomy is all about. And so I'd like to show you this. This is a right shoulder. You can see the deltoid pectoral notch. A very important muscle here on the left of the screen is the deltoid, then the pectoralis major, and you see the sternocleidomastoid, and here you can see the fibers with the attachment on the acromion and the posterior part of the lateral third of the clavicle, the high trapezius. When we speak of the shoulder, in this case from the anterior portion, we have to know the skeletal and also the neurological anatomy. In fact, under the clavicle, there is the brachial plexus, that is a very important structure that has a relationship, so to speak, with the muscular tissue and the bone tissue, a relationship that we must know. Now let's have a look at left shoulder. This is the scapula, and in particular some muscles. For instance, you can see the serratus anterior, the low trapezius, the lower rhomboid, the latissimus dorsi, and you see that the latissimus dorsi covers the lower portion of the scapula. This image is very interesting because it shows you that these muscles work together, so much so that some fibers end up into the fibers of the surrounding muscle. This is a right shoulder, and you can see here the lower trapezius. You see right shoulder, this is the lower trapezius. We turn it upside down. At this level you can see the scapula, you see the lower rhomboid, the deltoid, and it's very interesting at this level to see the relationship between the lower trapezius and the deltoid. This is the scapula again. You see the lower rhomboid, the serratus anterior, the latissimus dorsi, and here there is the serratus anterior and also the subscapularis muscle. So you see that this joint is extremely complex with a series of functions. We're going to talk about that later on. This is the right shoulder. Let's just imagine the follow-through. You see that the latissimus dorsi, this particularly large muscle, basically covers and stabilizes the scapula on the thorax. So the scapula must guarantee dynamic stability. This image is very clear. It shows the latissimus dorsi, the lower angle of the scapula, and you can see that this large muscle covers and stabilizes this joint. the same muscle, latissimus dorsi. So you see it is turned upside down, and you can see that there is the muscular component, but there is also a tendon component. In particular, you can see this here, so much so that this tendon of the latissimus dorsi in the massive calf lesion, but also in reverse prosthesis with deficit of external rotation, is used as a transfer because of the important characteristics that this muscle has, in particular this tendon that has its attachment phased to the serratus anterior. This is an important muscle. Basically, this is the queen of the shoulder, the serratus anterior, which is important basically because it is the pilot of the rotation, of the translation of the scapulothoracic joint. It is a very important muscle, and there are also different tests, some of them quite controversial, I might add, which show quite clearly how this muscle is important. And many researchers are working hard in order to better understand its characteristics. Once again, a right shoulder seen from the back. This is the lower trapezius, the posterior attachment of the deltoid. This is the spine of the scapula. This is the infraspinatus muscle. And you can see the relationship between the posterior deltoid and the infraspinatus. Right shoulder seen from the back. Once again, here we made research. Some nerves develop on the posterior portion of the shoulder, the radial nerve, the axillary nerve, with a very close relationship among these muscular structures. What is the rationale of my presentation? What is the most important message? Is the following. It is important to see the shoulder as a sort of a victim from the clinical viewpoint of something incorrect which might happen in another place, far from the shoulder, from the biomechanical viewpoint. Let's imagine you have a car. So the convergence is not working properly, so there is a problem with the wheels. If we change, replace the wheels, but if we do not solve the problem, that is the convergence and the balance of the machine or the car, every 5-6 months we have to replace the tires. So we have made an equation. The balancing and the convergence of a car, basically, represented the posture, the control, dynamic control of the core of the scapulothoracic joint, just like the wheels play a role, just like the rotator cuff. What does it mean? If we repair the rotator cuff, but we cannot understand what is the cause that led to the cuff tear, we might have some success. But in the long term, there will be a lack of success, which is not due to a bad rehabilitation or a problem with the surgeon. But the problems are due to the fact that we've not focused on the problem. We've not understood correctly the causes, which over time, slowly but progressively and frequently, in an atraumatic way, lead to rotator cuff tear. This is a dynamic contact between acromion and the top of the rotator cuff. This is what I call subacromial dynamic impingement. The scapula is the seat of the attachment of many muscles, the origin of many muscles, but its role is to transfer the energy from the bottom to the top, guaranteeing dynamic stability. You know that in order to correctly transfer energy from the bottom in the proximal distal way, it is necessary to have a stable basis. And only if you have a stable basis, if you have a stability of the lower limb, is possible to transfer energy through the kinetic chain from the bottom towards the top. That is, towards rings which are smaller and smaller, and as a consequence, quicker and quicker. This is a biomechanical mechanism that allows us to understand the transfer of energy. I'll stop with these images. Our right shoulder seen from the back. You see the lower trapezius, the serratus anterior, and the high trapezius. These are muscles which function correctly to orientate the acromion and the glenoid cavity compared to the head of the humerus. But just look at what happens when these muscles, regardless of the cause, are tired or if they are not working properly. The scapula becomes unstable. Dyskinesis of the scapula on the chest. The scapula is lighter than the humerus and of the arm, and then the arm. So the contraction of the deltoid acts so that the scapula is in protraction. Its retraction is delayed, thus reducing the subacromial space. As a consequence, the tendons and the biceps are compressed exactly in the subacromial space. However, if we surgically treat these lesions, but then with rehabilitation treatment we do not give stability to the core and the scapulothoracic joint, we run the risk of having recurrences if the patients undergo surgery. On the contrary, through rehabilitation treatment that has to be focused and correctly developed, it might be better to avoid surgery with our patients using a specific rehabilitation protocol. As I said before, the scapula has a role on the acromion but also on the glenoid. And when there are dyskinesias or when we lose the control of the scapula on the chest, there might also be instability. And there are specific patterns. Instability is extremely complex, multidirectional, voluntary, functional. You see, this is a case of instability of the posterior position that is partially due to a problem with the glenoid or laxity, but as you can see, many patients, the control of the scapula, you can see that very well here, represents the basis of the pathology. So, rather than acting surgically on these patients, a correction of the balance and of the control of the scapula represents the ideal approach. I like this video because this shows quite clearly this boy with a posterior position instability, with a scapula that is oriented in space almost to promote this dislocation. At the moment in which we stabilize it, the patient does not dislocate at all. And also the biceps, the slap lesions. Slap lesions very frequently correlate with lack or imperfect control of the scapula on the chest. That's about it. Thank you very much for your attention. And now I would like to give the floor to our dear friend Ben Kibler. Hi Ben, welcome to Rome, and hello to Kentucky as well.
Thank you. Thank you very much. Okay, can everybody see this all right? Are we okay here?
Assolutamente sì.
Yes, perfectly. Go ahead.
Great. Giovanni, first of all, thank you very much. It's always a pleasure to see you and talk with you. That's an excellent introduction. Good, a lot of things to talk about. You asked me to talk a little bit about how we've looked at the scapula over these years and how we evaluate the scapula to form a basis for treatment. So to understand dyskinesis, we have to decide what kinesis or normal motion is. And we can say that obviously the kinesis is normal scapular resting position, as well as dynamic motion with arm motion. Dyskinesis is the Greek for alteration of kinesis. This was a term that was established many years ago. It basically represents altered scapular resting position and altered scapular dynamic motion. We know that it's not a diagnosis, but it is an impairment, a difficulty in doing normal activities that you so well showed in your video. Therefore, it needs to be evaluated as part of the treatment of shoulder problems. So this problem is dynamic. Why is this dyskinesis an important finding? We've decided that it represents an impairment of the two most important scapular mechanical roles, which is, as you mentioned, mobility and stability to the shoulder. First of all, mobility is the requirement of putting the shoulder blade in motion to place the scapula and the arm in the functional position. You've got to move it along the ribs to put the arm in the right position. We know that this occurs. This is a video from some of our work. We know that it goes into external rotation, posterior tilt, and upward rotation, so that the glenoid is in the best position for the arm to function. Now, once it gets into that position, it has to be dynamically stable, as you showed. In other words, the arm, as it moves on the glenoid, on the scapula, has to be stable throughout the entire range of motion in whatever activity it happens to be. Throwing a baseball, lifting, working, swimming, the ball and socket have to be dynamically stable. Therefore, the scapula needs to follow humeral motion. We know that from many studies that the motion of the shoulder blade, it rotates up around a center of rotation that is next to the medial border of the scapular spine. And then as the arm elevates, it moves out to the AC joint to stabilize so that the arm can work in the overhead fashion. In other words, it has to be mobile enough to place the arm in position, but then it has to be stable enough so that the ball and socket are maintained throughout the motions of the scapula and the arm. Now, scapular dyskinesis is defined as the observed or measured alterations of the disruptions of this resting position or dynamic motion. It's very common in asymptomatic people, but it's also very common in people who have symptoms. It's not a clinical diagnosis. It's an observational finding that then can be correlated with the clinical symptoms. It is an impairment of these scapular rolls, which then can affect function or injury, very commonly seen in patients with all types of shoulder pathology. And there are multiple reasons that the scapula does not move normally. Our job is to understand those reasons, therefore to promote a good treatment program. This is what you see. You see the medial border of the scapula being asymmetrical, being prominent, with usually an elevation. We call this in general protraction. Once again, dynamically, that's the resting position. Now the dynamics are that the scapula goes from this altered resting position to a position that is quite obvious that it's in a dyskinetic pattern. You can observe this. You can see this very easily, and we'll go through this on the exam. This is what it looks like in our mechanical studies. You can see that on the right side, the scapula sits with a protracted position, does not elevate well. You see the alterations of the scapula of the thorax trying to elevate the arm. And we can see this looking from the top, and you can see this even better, that this right scapula never posteriorly tilts, it never upwardly rotates. This is the basis for what you were talking about with this external impingement. The acromion does not get out of the way of the moving humerus. Operating on this to do an acromioplasty will not help the symptoms because you have not helped the problem, which is the motion of the scapula. There are lots of reasons that we've discovered several reasons that this can occur. From the standpoint of pathoanatomy, actually things that may need to be operated on, you can talk about cervical disc disease, you can talk about nerve injuries, talk about post-traumatic scapular muscle detachment, snapping scapula. Sometimes you have to operate on a really tight pectoralis minor. Injuries to the strut of the clavicle or the AC joint will create dyskinesis. And then injuries to the internal derangement, labral injuries, biceps injuries by inhibition will cause scapular dyskinesis as well. So these are the things that you may need to operate on to restore the dyskinesis. However, there's a whole lot more problems with the muscle function, the pathophysiology, ranging from tightness of the upper trapezius or the lower trapezius to a very common thing that I'm going to talk about a little bit more called loss of voluntary muscle control. Core weakness is very, very common on over half of the patients. Once again, pectoralis minor tightness, alteration of glenohumeral motion. Very commonly, that large latissimus dorsi can be tight, and by pulling on the humerus can create scapular dyskinesis. And then most commonly, serratus anterior weakness or tightness is very commonly seen. A combination of serratus anterior and lower trapezius weakness with latissimus dorsi and pectoralis minor tightness, we call it SALTI, S-A-L-T-I, is very, very common as a group of pathophysiologic problems associated with scapular dyskinesis. So that's the problem. Now, how are we going to look for it? So the examination of the scapula has three parts. The first part is to establish the presence or absence of the dyskinesis, qualitatively by observation or quantitatively by measurement. That will tell you if scapular dyskinesis is present. Then you have to decide whether this observed or measured dyskinesis has any relationship to the symptoms. We use what we call corrective maneuvers to establish by changing scapular motion, does this change the symptoms? That tells us how scapular dyskinesis can affect the symptoms. Then finally, we have to assess that group of causative factors, because then that tells us what is causing the dyskinesis. So I'll go through these steps with you. So we can use a treatment, an evaluation pathway. So the first is to establish the presence or absence of the dyskinesis. The most common go-to test for the presence of absence is called the dynamic stability test, scapular dyskinesis test. You look at the dynamic motion of the scapula along the medial border, and you say, do you see it or you don't? Yes or no. Turns out that you can do a few more repetitions, add a little weight, that'll bring this out a little bit more. And it turns out that this is a very good test. It correlates very well with the actual motion of the bone. We've looked at bone pins and other studies, found out that if you can see it with your eyes through the skin, then that really does exist. Now, this is a qualitative evaluation that is pretty good, and it's the go-to test. Now, there is a device, there's among other devices, I'm a consultant for this device called Show Motion, which is more quantitative. We're working on this, I know Todd's worked with this a lot, to be able to actually quantitate motions. So you can do this type of evaluation where you look at the three different motions of the scapula from the arm down side, the arm elevation, watch their patterns. This is a normal situation. Now, if you have an abnormal situation, this is a patient with a labral injury, you can see that as the arm gets overhead, there's an alteration in anterior tilt and internal rotation of the scapula, which would be, once again, these bad things that are going on with the scapula. So we've been able to correlate this a little bit better. So we can say that, yes, scapular dyskinesis exists. Now we then associate this existence with the clinical symptoms by doing a couple of tests. One is called the scapular assistance test, where we assist dynamically this upward motion and posterior tilt. A positive test is if we find improvement in the smoothness of the arm motion, the amount of arm elevation, and relief of impingement symptoms. We know that indeed what this does is actually increase the amount of posterior tilt of the scapula, therefore freeing this up to move into more functional overhead positions. Now, the scapular retraction test, you manually stabilize the scapula in retraction. You assist external rotation and posterior tilt. Positive test here is that you improve the observed demonstrated forward flexion strength, or you change the symptoms of labral evaluation, what's called a dynamic labral shear test. So therefore, you have decided that indeed this finding is associated with symptoms, and you can change those symptoms by doing these corrective maneuvers. Therefore, you need to go through the entire protocol here for evaluation. Now, I can show you a little bit more detail in a minute how to do these tests. But basically what we found, we looked over 2 years, we looked at 426 patients with shoulder problem that had clinically relevant scapular dyskinesis, and we looked at what were the causative factors. We found that pathoanatomy, those surgical causes, were about a third of the cases, only a third of the cases. They were mainly labral injuries or biceps injuries, clavicle fractures or AC joint problems, scapular muscle injury, or other nerve injuries. That made up a third of these patients in a very large series. Therefore, if we were only going to operate on these, we would not be able to treat the other 2/3. So only 1/3 of the patients have something you can operate on easily. Here's an example of some of these anatomical problems. This is a patient with a labral injury. He has a positive, what we call DLS test. He has pain in the posterior joint line as you bring him arm into this position. It hurts. Now, if you take the scapula into retraction, stabilize him by moving the glenoid, moving the scapula, now his internal impingement is relieved, therefore showing you that the anatomic problem may get better with therapy as part of the treatment. We do know, once again, that the sequelae of fractures of the clavicle can create this altered position, the scapular dyskinesis. And we can do this in the early stages. This patient is 2 weeks after a fall off of the bicycle. He has minimal pain at the clavicle. He has problems with impingement as he tries to raise his arm. He cannot raise his arm because he has pain over the acromion, not over the fractured site, but over the acromion. And if you look at him from behind, you'll see that this position creates a scapular protraction. Therefore, to treat the scapular protraction, you have to treat the clavicle fracture and put it into the right position. We can do a dynamic maneuver here, get his scapula back, and all of a sudden, not only does it not hurt, he has better arm motion. So therefore, that means that you probably need to treat this surgically. Similarly, AC joint injuries. You can see this obvious AC joint problem that I can change and by the observation just by moving his scapula around. Now, get rid of the dynamics by putting the scapula in a retracted position. That shows you that, once again, that fixing the scapular problem and the impingement is going to be only done if you fix the AC joint. Now, you have also these problems here with the nerve injuries, with this very bad situation where you have this problem with serratus anterior palsy. The arm cannot go overhead. You have obviously the upper spinal accessory nerve problem with trapezius injury that shows the dyskinesis. And then you have this post-traumatic scapular dyskinesis with a tear of the lower trapezius and rhomboids, with the obvious problem with the scapular dyskinesis. Now, the non-surgical problems are very, very common. And once again, they have to do with motion. This is a very important paper that can be broken down into the reasons for these motion abnormalities. And they're mechanical, either primary scapulothoracic or primary humeral motion. And once again, how you break this down, how you treat it. So I want to show you how this, what we call salty, serratus anterior weakness or inhibition, lower trapezius weakness, pectoralis minor tightness, upper trapezius tightness, latissimus dorsi tightness occur in 2/3 of these problems with motion. They occur as a group. Therefore, they have to be treated as a group. Now, we also notice that, once again, weakness of the hip and core is very common with scapular dyskinesia. So you can do a one-leg stability series to see the loss of control of the core, which you have to work on first before you can ever get the scapula to work normally. Impingement is, as Giovanni said, a victim and culprit situation. The impingement symptoms are the victim, but the problem is scapular protraction, which creates the impingement. We can measure pectoralis minor tightness several ways, either by measuring with a tape measure or by actually doing a square device off of the wall. This is the scapular. This is a video of the scapular assistance of scapular retraction. You have them move the arm and overhead. They have a certain range of motion. You can dynamically stabilize the scapula and show the increased range of motion and relief of symptoms. The patient says, that's the way my arm is supposed to move. Scapular retraction test is the same type of situation. You demonstrate by whatever measure you wish, forward flexion strength, either measured by dynamometer or grading it, put the arm in scapular retraction, test it again, you'll find that there's a grade higher, and we demonstrated 24% improvement in demonstrated strength with that. That also means that whenever you are testing for rotator cuff or forward flexion strength, you should always do it off of a stabilized scapula. Once again, here's the finding right here, where you actually have this test called a low row, where you have weakness, you have them push back against you. That shows you that they cannot control scapular position. This is a loss of voluntary control. Loss of voluntary control means that they cannot stabilize the scapula in retraction. So all the exercises that you may try to do to strengthen the serratus anterior will not work because the serratus anterior is not activated well. You have to visually or tactily cue them so that they will put their scapula in the right position. This is very important because many patients with this problem with scapular pain after about 6 or 8 weeks will have this, and you will not know it unless you test for it, and therefore your therapy will not be successful. So how do we measure some of these strength? This is the way we do it in our facility. We measure serratus anterior strength by placing the arm forward flexion, apply downward resistance. And what you're looking for is, can the serratus anterior control the inferior medial border? That's what you want to know. And you can see that it doesn't work. So that's how you actually measure serratus anterior strength as far as the scapula is concerned. If you look at middle and lower trapezius strength, you do the same type of situation where you test and you monitor the medial border of the scapula. Can they maintain retraction? What you're testing is the ability. So what you're looking for is not, is the muscle strong, but can it do its job eccentrically to maintain retraction? Similarly, for the rhomboids, either prone, you put the humerus extended with the scapula retracted, or sitting, resisted arm extension. So thank you very much. This has been hopefully this is helpful. I love to be involved in the questions and look forward to it. Thank you.
Grazie, Dr. Kibler.
Thank you very much, Ben Kibler. Thank you. It's really an honor to have you tonight here. This is one of the lectures which we're going to study. Thank you very much for this. We have Todd with us, who will help us also to promote the discussion with the questions. We see that Dr. Bassem El Hassan is with us today. Hi, welcome. Hi, Bassem. Thank you.
It was very busy, so I'm glad I was able to make it. A very, very big day. Thank you very much for inviting
Thank you,
me.
Bassam. Welcome in Rome. Welcome in Rome.
I love Rome. It's fantastic. So, are you ready for me, or you have questions for Ben Kibler first?
Siamo pronti, siamo pronti.
Okay, we're pronti. Fine, sure.
Prego, vai, vai.
We're ready. Off you go.
Let me share my screen. In fact, I'm glad, like this is, as usual, this is fantastic talk by Ben Kibler. Ben Kibler is the father of Scapula, and I'm very glad that he gave us this very nice talk. I learned a lot from him over the years. I think my talk is very complementary to his talk. What I mean is you're gonna see, he said a lot of important principles, and I'm gonna add to them a little bit. So scapulothoracic abnormal motion, this is what I'm gonna talk about, and about certain of treatment. So why did I choose it? Please, for everyone, if you wanna use this kinesis the way Ben Kibler used it, go ahead, that's perfect. But unfortunately, most people, they don't. Over the years, why did I come up with this term? Because I get phone call. I have a patient who has dyskinesia, yeah, something in his shoulder. He may need something to be managed. Or they call me, no, the patient has winging, he needs surgery. All right, what does this mean? Like dyskinesia is dyskinesia, like whether it's bad or worse. So anyway, this is why I just changed it. So please understand that STAM, scapulothoracic abnormal motion, is the English. Yesterday I was talking to Ben about it. It's the English translation of dyskinesia. So my resident and fellows, they cannot say winging. They will say STAM, and we'll try to figure it out. If you want to use dyskinesia the way Ben Kibler used it, which is abnormal motion, great. But this is to essentially talk about any abnormality of the scapula. Oh, now, but I will add a little bit to what Ben Kibler said. When you say abnormal, what do you mean abnormal? Okay, what does it mean abnormal scapula? I'm not talking about measurement. Like he is much more scientific about determining. For me, I'm just saying more, just let me understand it slightly more. Well, I would say if someone come with a STAM, again, abnormal motion, they have limited motion and pain, maybe with instability, that's abnormal. Okay, it makes sense. But let me think a little bit more. Let me show you this. Is this abnormal? Now, if you can hear the music, the patient's dancing and dancing his scapula. Is this abnormal? This is where it becomes very, very tricky, by the way. This is where it becomes very tricky about talking about what's abnormal and what's not. And then we define on top of that certain principle, and we need to understand it very well. Now, why the scapula is so amazing and why its evaluation could be very challenging, this is one of these reasons. Like, it's very uncommon for someone who comes and they dislocate the shoulder normally, other than EDS, and you say this is like, they do it for fun. The scapula, because of how it is sitting and how it functions, you can get this category of patient that they can show you this abnormal looking scapula while they're completely normal. In fact, very quickly, if you remember, Ben, there is an AAOS, a specialty day that I brought a patient who's an orthopedic surgeon who will be able to do this for his scapula. The only person who figured it out is Ben Kibler. Everyone else, he need a pec transfer. He need whatever. And I told the orthopedic surgeon, please don't give it out until the very end. Then he told them, no, this is how I do. It has been this way for 15 years. I work with it. I play with it. So everyone was wrong because he was doing it for fun. It was not abnormal whenever it's not pathologic. And the scapula is the house of the rotator cuff and the deltoid. This is how amazing it is. And it is sitting on the posterior chest. And the shoulder girdle, the main component of the shoulder girdle is the scapula, which is the shoulder. So for whatever reason, people separate shoulder from scapula. I don't understand why. It's the same. And the shoulder girdle is AC joint, SC joint, scapulothoracic, the glenohumeral. And Ben Kibler talked about a lot of these can affect the shoulder for sure. Even the chest can affect them, okay? Now, if you look at the scapula, other than the connection between the SC and AC joint on the chest, only muscles, by the way, nothing else, which means if you separate it and take this muscle, it's gonna fall off. There's only nerve and arteries connecting them. And at the same time, I always ask this philosophical question. Why is the scapula sitting on the posterior chest? Why? Does anyone know? Like if someone hear me say, like, what are you talking about? It should be on the posterior chest, but why? Why is it not like in the axilla down? Why is it not tilted down? Why is it not in the anterior chest? Why is it not in the front? Now, because mentally we're not used to it, number one. And number two, we don't know that the barrel shape of the chest will, in order for the shoulder to move perfectly well, that's the right position of the scapula on the chest wall. And it needs to be stable. When Kibler talked about it, it likes to be stable for the shoulder motion to continue. Now, there are 6 periscapular muscles that hold, essentially stabilize the scapula on the chest wall. So other than the AC and the SC joint, these are only muscles holding the scapula. So you have the serratus, huge muscle. Trapezius, another huge muscle. And then you have levator scapulae, rhomboid minor, rhomboid major. Today, I did 2 of these, like triple transfer today. We're transferring these muscles. And we have the pectoralis minor. Now, the 2 most important large muscles are the serratus and the trapezius. Trapezius is quote unquote easier to examine. Why? Because you can see it. Serratus, you cannot see it. All the exam of the serratus is indirect, not direct. So these 2 muscles are very important. And the serratus specifically, as huge as it is, the most important part of the serratus is the distal part. And this part is the part goes to the distal scapula, keep it on the chest, and protract the scapula on the chest wall during motion. And the trapezius, we're going to talk about it in a minute, is the only muscle goes from the base of the neck and hold the scapula up. Now, this is very interesting. This is a scapula. This is the insertion of the distal serratus, was the most important part of the serratus. I detach it here in this cadaver. I'm going to put suture in it, and I'm going to hold the serratus temporarily. Now, see this what happened. When you move the shoulder into flexion, if you wing the scapula out, you're going to lock it. So I'm moving right now. The serratus keep protracting the scapula on the chest for the subacromial space to open for the flexion to happen. Now, without it, the scapula will wing out. Remember, I'm not saying wing out of the chest. It locked the subacromial space. You don't have flexion anymore. Now you bring the scapula back with the serratus, or later we're going to talk about pectoralis major transfer. Boom, you're protracting the scapula on the chest wall. Now you're able to flex your shoulder. That's the basic principle. This is why if this serratus is not working, what happened? You don't have that muscle that pull the scapula down on the chest wall to protract it. This is why you have this kind of motion. Now, if you mimic the scapula, the serratus function, you can call it the way you want, scapula compression, scapula stabilization, whatever you want. I'm reproducing the serratus function. You're going to get your full flexion if you have serratus paralysis. Okay? Now, the trapezius is the only muscle originating from the base of the neck attaching to the acromion, which means if it's not working, the shoulder is going to drop down and with an anterior tilt. I'll show you in a second. So right now, if you look, middle trapezius, lower trapezius, and upper trapezius. This is a connection. If you, as I told you, if you disconnect from the AC joint, the session is going to drop down. When it is paralyzed, the shoulder droop and with anterior tilt, not only droop. Notice how I'm pulling it posterior and up. And everyone, when they examine the trapezius paralysis, they examine drooping down. It's not only, it's too plain. Droop with an anterior tilt, always, because of the upper trapezius. Now, any patient with upper trapezius dysfunction, you're going to be able to see the levator scapulae, rhomboid minor, rhomboid major, the only time you can see them, and they have limited abduction because because you don't have this connection to the upper acromion to be able to clear, so they have limited abduction. And we're going to talk about the exam in a minute. Now, this is something I call a scapula positioning test. You can call it, again, like you've seen some of these tests similar to what Kibler, but this is slightly different because the difference between scapula compression test and scapula positioning test is why are we doing it for? When the scapula, you have serratus paralysis, the scapula wing off the chest, you need to compress. When the trapezius is paralyzed, you don't have, it doesn't stick as much out, but it droops down with anterior tilt. So you take it from this anterior tilt and back to reproduce the trapezius function, then you get the function back. So now what happens if both are paralyzed? You get this. This is, you see it in FSHD. No trapezius, no serratus. They have major stem or winging of the scapula of the chest wall. But still, if you reproduce the trapezius and serratus by compressing the scapula on the chest wall, you'll be able to do it. You'll be able to reproduce this muscle, then you're gonna be able to get the function back. Now, Can STEM originate from hyperactivity of certain, like pectoralis minor, or abnormal muscle activation? Because I showed you if the serratus is paralyzed, trapezius is paralyzed, the shoulder is going to be abnormal. Now, what happened in abnormal muscle activations? I showed you how patient can play with their scapula. So what is that line between playing and between pathologic? And this is what we're going to talk about it. Yes, you can. Definitely, you can have it. This patient has perfect muscles, serratus, there's no paralysis whatsoever, and she has major stem. Boom. So how can we determine that? Like, how can we determine? Like, it's so tricky. If someone coming with a pathologic stem, how can we determine whether it is serratus paralysis or trapezius paralysis or just simply abnormal muscle activation? This is what we have been using over and over now for the past few years. We're using surface EMG. Why? Because if you use regular EMG, everything's going to come back normal because you don't have muscle paralysis. But surface EMG can give you the activations, patterns of activation of the muscle around the shoulder, and what's normal, what's abnormal. So during normal shoulder motion, this is a very nice animation from University of Lyon showing what are the muscle usually activate during normal shoulder flexion. And what we saw, this is the majority, upper trapezius, anterior deltoid, pec major, serratus, rotator cuff. At the same time, we noticed that the muscles that the least activate until horizontal are pectoralis minor, rhomboid major, and latissimus dorsi. Okay? These are things like patient can see when you do them, you can see the curves and everything. Patient can witness how their muscle even work. Now, what happens when the patient have abnormal muscle activation? They can behave like stem with abnormal, like serratus paralysis or something similar. So when we did the surface EMG on them, this is what we noticed. They have hyperactivation of the pec minor, hyperactivation of the upper trapezius, hypoactivity of the serratus anterior. And this can create this abnormal motion. Now, this is a question I always get. Why? Why did this happen? Why this patient behave this way? You know, I'm not very sure I figured it out, but I'll give you this quick example. If you look at the trunk and the complexity of the trunk of the elephant, and you compare it to the human scapula, the trunk of the elephant has 40,000 muscles, 40,000. The whole human body has around 650 muscles. And among these, all the shoulder with the scapula, you have 14 muscles only. With 14 muscles, we're able to create all this crazy pattern of scapular abnormalities, while the trunk of the elephant, which has 40,000 muscle, they don't have this. Why? Well, we do believe this because it is related to the abnormality coming from the activation of the muscle coming from the brain. And this is what we are working on right now, on trying to determine the sequence, how this goes from the brain to the shoulder to create a stem that is not related to muscle paralysis. Now, because of the similarity between paralysis and the abnormal activation, what is the physical examination of choice that we can use to determine the abnormal muscle activation versus paralysis? Okay? So how to differentiate between the two? In the past, when we examined the serratus anterior, we do things similar to mandibular, slightly different. I used to do the shoulder flexion resistance test at 30 degrees, elbow extended against resistance, and we'll look at the scapula, how it wing off the chest. And it wing big time, it means the serratus is not able to bring the scapula on the chest. It means serratus is paralyzed. Hang here, keep this idea in your mind because we realized we were wrong about this one. The second one, the most common test used by everyone in the shoulder is the wall push-up test. And I'll tell you about it in a second as well. And the third one, if someone has paralysis, let's say brachial plexus, they cannot protract the scapula against the chest. They cannot do it. So in this case, we do what we call, if they cannot flex the shoulder, we do protraction against resistance. We let them protract, we resist it. And if the scapula wing of the chest, we know the serratus doesn't work. But then we realize over time that test number 1 and number 2, they're not reliable. How? When we did our surface, I will show you now, examine the surface EMG. This is shoulder flexion against resistance at 30 degrees. Every patient have a positive test. All these patients, upon exploration, visually, EMG, they're normal, perfectly normal serratus, and this test was positive. And they had the positive wall push-up test. even though the serratus was perfectly normal. But why? Why does this happen? This patient has trapezius paralysis, serratus is perfect. We did the wall push-up test, it is positive. Why is it positive? So we started to work on these, and this is what we noticed from surface EMG. When you flex the shoulder at 30 degrees with the elbow extended against resistance, we noticed that you can engage the pec minor to tilt the scapula forward. You go to 60 degrees, you can still engage the pec minor upper trapezius. The minute you go above 90 degrees, it's very hard to engage any of these muscles to tilt the scapula forward anymore. So the key for the test is to go to the 100 degrees. So this is our SFRT, 30, 60, 100. So this patient is positive at 30, positive at 60, negative at 100, the serratus is perfect. This patient the same, positive at 30 and 60 some, we went to 100, we position it, against resistance is negative, her test is negative. It means whenever we do SFRT, 30, 60, 100, we know whether the serratus is working or not. And this is, I'm not sure if Victor Nola is here on this call, but this is him. He sent me the test. He has been using it back at home for patients who have abnormal scapular motion. And he was able to determine whether or not the serratus was paralyzed. But what happened if the serratus is paralyzed? The test is positive at 30, 60, and 100. Any angle against resistance, the scapula is going to wing off the chest wall. And this is, you can see the 30, 60, and 100. Okay? And we published about our test, the serratus anterior dysfunction examination, the wall push-up versus SFRT. It is now in the JSES. And now I'm going to go over the new classification we came up with, and then we'll see if we have time to go for treatment, and you let me know. So this is scapulothoracic abnormal motion in patients who have no shoulder pain, no SC joint, no AC joint, none of this. He can have combination, but this is not their major problem, mainly the scapula. And we notice this is what we have. STAMP type 1, patient who have pec minor hyperactivity, they have slight anterior tilt of the scapula, tenderness over the pectoralis minor, and some limitation of motion. And surface EMG showed that they had hyperactivity of pectoralis minor. STAMP 2, they have 2A and 2B. 2A is, both of them, they're similar in terms of the scapula kind of wing of the chest whenever they flex the shoulder. But 2A is very easy to stabilize the scapula on the chest, and they can flex it fully. And 2B, when you try to stabilize the scapula, put it where it's supposed to be happy, the patient tried to resist you. And it will become harder to push it, keep it on the chest, but eventually they're able to flex their shoulder. That's the difference between STAMP 2A and 2B. So I'm trying literally to push it very hard. She's trying to push against me instead of being happy with it, and then eventually they get the shoulder motion. Both of them, their SFRT is negative, which means the serratus is perfect. It's just abnormal activations of the muscle around the scapula. STEM 3 is typical serratus paralysis. So, and they have SFRT positive at 30, 60, and 100. The type 4 is the trapezius paralysis. And we're going to talk about the exam. And usually this one, the SFRT, again, is negative in the trapezius portion. They look like as if they have a problem with, quote unquote, they call it winging, which is the stem. But if you do your SFRT at low angle, they wing out. You put it at a high angle, they do very well. This is mostly a trapezius paralysis, and serratus is perfect. Type 5 is both. FSHD, most of them, it means trapezius and serratus are paralyzed. Now, type 6, and I know Ben Kibler have seen this before. Type 6 are those, even though the scapula wants to sit on the chest wall, these patients, they don't like to keep the scapula on the chest wall. They look almost like dystonia. They come to you, the scapula is sticking out, and it's impossible to reduce it. It doesn't make sense because the scapula wants to be on the chest, and you cannot reduce it. You try anything you want, you cannot reduce it. But these patients, who are usually young, female, and you can see all the muscle activating at the same time, when they don't have any bony abnormalities, you know it's spastic kind of form of abnormal muscle. And the only way you can prove it is this. Under anesthesia, you examine the patient. With one finger, you can move the scapula the way you want. And many times we do it with the mother in the room because they don't believe it. I'll tell them, like, let's take a look. And you can move the scapula the way you want because they're holding it. There's nothing else abnormal. That's type 6. Type 7, we have 7A and 7B. 7A is, I call it the dancing scapula. Whenever they move, they start to dance. And 7B, we're gonna see it's ongoing, it's dancing scapula. This is 7B. At rest, it keeps on going. It feels like seizure. Okay? So these are the STEM classifications that we have. Now, I just want to make sure, like, do we have time still for treatment, or shall I stop here? Giovanni?
Proceed. Go on, proceed.
Okay.
Go ahead.
So very quickly, I cannot go into every single classification, what you do for it, but I will show you the majority. For STEM 1, which is like only pec-minor hyperactivity, of course, they have done core and hips and proprioception. They don't have weak hips. We're talking about they've done all the rehab possible. Even they've done sometime Botox for the pec did not work. You can go arthroscopically release the pec-minor. This is for type 1. For type 2A and 2B, similarly, we do what we call sexy pexy or pectoralis minor release scapula pexy. So what usually we do, the patient in the lateral position, we put the scope lateral, all of you know how to do this, and we go anteriorly, medially. This is really very quick, medial to the coracoid, and just release the pectoralis minor tendon arthroscopically. And usually with this one, any patient who have a positive TNL for brachial plexus, you can do brachial plexus and urethritis at the same time if the patient have positive TNL. And the scapula pexy is essentially putting the hand behind the back. You make smiling incision at the distal tip of the scapula. You see the latissimus first retracted distally. Every patient, we do a video of the serratus to show it's perfectly normal. And you take video, show it to the patient. This way they don't tell us anymore abnormal EMG. This is serratus, looks perfectly normal. And then we're gonna expose the scapulothoracic bursa, which is this area in between the two, between the rhomboid and between the rhomboid major and the serratus. This is scapulothoracic bursa area. And then we expose the rib at this level. Usually it's rib number 6 or 7. Now we're gonna pass tendon around it through the scapula and tie it. The purpose of it is just to keep the scapula in position for a few weeks. That tendon is gonna eventually stretch. I don't like to use wires. I will not use sutures, only tendon, because it's gonna stretch after 2 to 3 months maximum. Its job is with the pec minor to position the scapula correctly and re-educate, reanimate the muscles activations and getting patient back on track. These are for the resistant cases that you've done everything and nothing else worked. And you can see now how the allograft, usually I use allograft, you can use hamstring if you want, and you pass it around the rib through the scapula and then you tie it. We've done a lot of these. Last year only we've done 73 of these, and we had really, really very good outcome for patients, especially for type 2A and for type 2B. Now, some of you may ask, like, well, can you try to use shoulder pacemaker? We need to discuss it maybe at the very end, because in my population, it did not work. And may it work in only one very specific type of patient. We can talk about it later. So we've done a lot. These videos from patient, they're home at the time of COVID. You can see like, they're all of them. This patient has it bilaterally. She's done extremely, extremely well. We have like this patient, they're really doing well. This patient has posterior instability with the stem that she has. And this is her 6 weeks. She went back to kickboxing after 8 weeks from her surgery. And when they brought her to me for capsular shift, because she was subluxating the shoulder scapula this way and pec major transfer, which she doesn't need either. She needed a 35-minute surgery and that's it. And we publish about this one. You can read about it. If not, I'm happy to share it with you as well. Now, in patients who have this kind of tight type 6, they are so strong that if you do the sexy pexy or pec minor release scapula pexy, they cannot hold. And these patients, we tried Botox, we tried everything. This is the only potential way they get better, right to left scapula tethering. And what we do essentially with an Achilles tendon allograft, we tie the right to left scapula in real significantly retracted position, so that they don't go back to that position, which is the front position. And we use this one also for type 7A and 7B. And we're gonna publish about this as well. By the way, these are desperate cases. They have the symptom for years. They've tried everything. They had the prior surgeries. We tried virtual reality, everything else. I will never do this one except everything is exhausted. And this is a patient I showed you. This tonic, you cannot move her, you cannot reduce her. This is her only like around 3 months after surgery. And you can see the tethering right and left. And she's doing really, really very well. Now for stamp 3, this is quick. Stamp 3, we went from pure abnormal activation to true paralysis. We do a pec transfer, and I usually use only the sternal head with the bony insertion of the sternal head of the pectoralis major. We harvested, we exposed the distal scapula, and we transferred the pec from anterior to posterior to reconstruct the serratus anterior. Remember, the job of this muscle is to pull the distal scapula and keep it on the chest the way the serratus does. And this is why it works very well for patients who have true paralysis. They have to have true paralysis. I cannot tell you how many times I have patients, they have this surgery done on, and then I realized the serratus was normal, mainly because the exam was not correct or EMG showed subabnormality. So this is bone-to-bone attachment. And these are some examples of patients. I've done a lot of these, like in the first 10 years of my practice. Now they're much less because many of these patients, I feel we can do lesser surgery like pec plantar release or scapulopexy, even though I've done more than 250 of these. For the trapezius paralysis, we have the triple transfer, which is not the Eden Lang, is modification. In fact, we did 2 today. And this is you can see the trapeze completely paralyzed, the patient in the lateral position. We're trying to recreate the trapezius. So what we do is we harvest the levator scapulae, rhomboid minor, rhomboid major separately with bony insertion. And we're gonna transfer all of them to the spine of the scapula, like the trapezius. The trapezius, usually it is attached to the acromion, clavicle, and spine of the scapula. And this is how you're supposed to attach these. The Eden Lang, they take the rhomboid and rhomboid transfer to the body of the scapula. This is why we tested it biomechanically and kinematically, and it was not the right transfer. So this is a rhomboid major, and you already levator scapulae and rhomboid minor. Now we have the 3 muscle, we debride the acromion and the scapular spine, and we use a lot of sutures for the attachment. Usually 4 double for the levator, 2 double for the rhomboid minor, and 4 double for the rhomboid major. And we lateralize them. And you're gonna see at the very end, they will look after transfer like a trapezius. For the rhomboid major, we fish mouse it, we break the bone, and we proximally attach one side and distally one side. And then you can see how the trapezius look almost like the triple transfer. These patients, both of them are 10 years after surgery. They're doing awesome, magnificent. Now, last but not least, when you don't have either muscle, the best, most reliable option is scapulothoracic fusion. With scapulothoracic fusion, usually we place the patient in the prone position. We place the arm in flex position because remember, you need to clear up the subacromial space. Wherever the scapula sit on the chest, you expose the rib at those levels. Usually we try to aim between 5 to 6 ribs, and we prepare them, and we debride them, and we prepare them. The undersurface of the scapula, we also debride and prepare for the attachment. We always use plates because the plate on the scapula protect the bone from cutting. I don't use wires anymore. I use only circular sutures. I have no financial interest from Arthrex because this circular suture, they're very easy to pass along through the hole and around the ribs. Very, very nice and easy. And make the surgery very quick. Honestly, whenever everything going well, it should not take more than an hour 10 minutes, or an hour and a half maximum. This is a tensioner that we tension it between 60 to 80 newtons. And that's it. We tie all of them and then you cut and you'll be done. So this is a scapulothoracic fusion whenever you don't have any other option. And the patient do extremely well if you position the scapula correct and fuse it correctly. And in conclusion, the majority of the stamp cases now I deal with could be the result of abnormal muscle activation around the scapulothoracic articulation. Management of stem requires very good understanding of the anatomy and pathology around the scapulothoracic area. Surgical reconstruction can lead to very good outcome. And there might be a role for the shoulder pacemaker for one category of stem with shoulder instability, and further studies need to be done and determined. And thank you very much.
Grazie mille, Bassem, grazie infinite.
Thank you. As usual, you make us understand that we really know very little about this joint and that we have to study quite a lot. I'd like to give the floor to Todd Ellenbecker, who is with us. And I'd like to give him the honor to ask questions to our speakers. Todd, there you go.
Thank you very much, Giovanni, and congratulations to both doctors. Truly amazing lectures, and I've had the privilege of hearing them before. And these talks, every time I hear it, it gives me more information. And like I said, truly impressive. One question for each. Dr. Al-Hassan, question for you in your shoulder flexion test, which is very eloquent, and I've been using it for some time and find it very helpful. With your EMG work, did you find that there was any difference in whether the shoulder is externally rotated as you do the test or internally rotated? Or you might even think more simply as supinated position of the forearm or pronated position of the forearm. Does it have any effect on the EMG from a synergistic pattern for the physios out here that want to actually use this test in their own examination?
Well, that's an excellent point. In fact, in terms of the rotation, I try to be more consistent about it, like the way I do the test, because you know, it is really easy but slightly tricky sometimes. The minute the patient activate the pec manner, even though you want to position them at 100, it can be positive. You have to make sure to let them relax, really relax the shoulder, hold the shoulder, tell them relax, and you pull the scapula slightly forward and hold it at 100, usually with the thumb up. I usually don't change it. I have been using it all the time this way. And whenever in this position and it locks, and tell them try to hold it, it is almost 100% of the time, because what happened with me, the first 30%, when I say 30 degrees and they have positive test, when I opened, they were normal. The serratus was perfect. And now the 100 cases or more that I've done with the sexy pexy, every case I explored the serratus, it was normal. So I realized we were doing something wrong with the exam, because we rely on the wall push-up test, which is in every book. And it is not accurate, by the way. Many times the patient can do, if they want to do, they do it and they can tilt the scapula up and they can fool it. So anyway, I will do it in one way and consistently. And now my team, they're doing it exactly the same. And I would love to hear how it's going to be when you see more and more patients, if you feel there's anything need to be done differently. But this is my way to go. I don't look at the EMG anymore after this test.
No, I wanted to be sure for the audience that we do it exactly the way you do it as the pioneer of the test. And again, with your huge success with it, just to be sure we were into all the details. Question
so
for
if
Dr.
you look at my hand, very
Go ahead,
important.
sorry.
Yeah, the thumb is up. The 30 degrees, almost always, they can wing it out because they can get the upper trap in the pec manner and they can wing it out. Sometime with the 60, then you let them relax, you hold the arm yourself and you move it forward and make sure that they're not doing anything at this time, and you make sure the scapula is here, tell them hold it. Sometimes they want to play, they hold it only for 1 second, they go. The minute they held it in this position, that's it. And try to push, you know, it's intact. This is the way a test is supposed to be.
Okay, very good. Dr. Kibler, you've taught us through the years so much, and I've benefited greatly with how you've increased the awareness as rehabilitation specialists, that it's not, when we work with shoulder patients, it's not all about just jumping on the rotator cuff. We know the rotator cuff is extremely important, but many times it's overlooked by physios, the importance of looking at the scapula and exercising the scapula. How have you, through your career, worked with therapists to help them to understand, and what is your recommendation for starting with scapular exercises primarily, or do you do them concomitantly with the rotator cuff exercises so they're developing together? I think we could benefit a great deal from your wisdom in that area.
Thank you, Todd. Couple of points. What are you trying to do with rehabilitation? You're trying to replicate function, and you're trying to replicate normal physiology. Well, if you do any test, you find that if you're going to test this position right here, if you look at EMGs, the very first muscles that work are in your legs and your hip and your trunk. And therefore, if that's what you're trying to replicate, then that's where you need to go. Now, in all of our experience, once again, this loss of voluntary control is such a real problem that unless you get the facilitation right, then the end result is not going to be very good as well. So I agree with Bassem. This pectoralis minor is just such a nasty thing, gets in our way.
Annoying.
And so but I'll tell you what, it does work in the throwing athlete in the overhead position. I mean, when you're here, the only thing that's keeping the scapula from falling off the back of the shoulder is the pectoralis minor. That's the only muscle that attaches between the rib cage and the scapula. And so in this position, so it is important up here. It's not important. It's a problem down here. But so you got to look at the pectoralis minor, but you've got to get that facilitation of the hip and trunk first. And then so we start with down to the side, short lever arm, cueing to make sure that we can get that serratus working well. Now, so the serratus inferior part is very important when you first start, but when you get up here, the serratus, the upper part, becomes a very important role along with the low trap. And I like what Bassam's doing with this differential positioning right here. And I think this overhead really shows that the serratus does kick in. And so we will start closed chain, short lever arm, below shoulder level, hip and core, pectoralis minor as our first attack. Then when we get control of that, then we'll start moving up to doing more eccentric, more off the wall. And the rotator cuff is by far the last group. You know, that's the end of the line. You can't get anywhere, as Giovanni said, you can't get anywhere unless the base is in good shape. So I think you need to go in that direction first. The other thing that I think is going on when you get your arm up here, we've developed a model of the scapula, and we've clued in all these muscles. This is a physical model. We find that the low trap with the arm up here is an external rotator as well. So it actually helps hold the scapula back when you get the arm up in this position here. So I think probably the external rotation is playing a role with this posterior positioning of the scapula as well.
Both of you, just to throw out, I think for the audience as well, is both of you using different terminology have basically used the scapular assistance test. And I found, Dr. Kibler, you taught me that years and years ago. And for the patient who has very subtle scapular pathology, we saw very, very severe scapular pathology in our presentation today. But in the overhead athlete, for example, that has very subtle scapular dysfunction, perhaps, can you comment a little bit, both of you, how you use that test? Because I know in my own hands, that's probably one of the most important tests, more than visual observation and more than many things, to be able to convey to the athlete that having abnormal scapular movement has an effect on the glenohumeral joint and maybe their impingement pain, their instability, their bicep tendonitis, tendinosis, whatever terminology. And that test has just been so important to me. And again, if you each could just summarize how you've used that test, I think it would be important for our audience.
Well, once again, you're talking about function. You're talking about why is the patient in your office? The patient is in your office because they can't do something. And it's up to you to kind of demonstrate and help them to understand that. And so they can't see the scapula. They can't see what's going on back there. They can't feel it, but they know that they can't move their arm in this position, or they get a click or catch when they do that. And you're back there doing something to them, and it changes the dynamic motion, and they feel better and they get more motion. Then they, first of all, know that you know what you're doing. Second of all, what you did makes sense. Third, will tend to buy in. Remember, all these tests are just to demonstrate the function. So all these tests for strength is just demonstrating, can that muscle that you're testing do what you want it to do, which is to maintain the scapula in retraction or controlled motion. So that's what you're trying to do with any of these tests. So the scapular assistance is very helpful from that standpoint. And it is for a mild case. Now, I like Bassam's 2A and 2B because there are patients you try to do the scapular assistance and it makes them worse. There's no doubt. Yes. They will not tolerate that well. And those are the ones that they start firing that pec just as soon as you do anything back there, which tells you got to spend more time on that pec than you have to do on anything else. If you try to get your arm away from the body, they're not going to work well. You've got to get their arm back, scapula back and down, however you do that. And that pec minor is your major player in that situation for the 2Bs.
Exactly. And I felt this is why our presentation was complimentary, because he talked about, essentially, he covered all the base, everything, but also talking specifically about dyskinesis or STAM related to shoulder pathology or other pathologies. It is very important for the patient to know why, if the scapula change position, it can affect the function. So the type I showed you right now, many times when I try to press the scapula on the chest wall and the patient cannot, they're fighting you. They don't understand why it's supposed to be on the chest wall. And I tell them, like, the scapula like to be in its happy place. So usually what I try to do is I go to the normal shoulder, I asked the patient to put the hand behind their back. I tilted and I put my hand underneath the scapula tip. I told them, move your arm right now. And they get locked. They said, like, what's happening? I told them, well, I'm reproducing what's happening in this shoulder. This is number one. Number two, as Ben said exactly, any test, you can say it the way you want. The purpose of the test is to produce the function of the muscle. When you flex your shoulder, the serratus keep the scapula on the chest and help with the protraction. So if you have, and this is how we do it, if the scapula is winging out, you want to put it back where it's supposed to be. That's number one. If the shoulder is drooped, not winging out, is drooped down, even if you do compression test, it's not going to work. You have to bring it where it's supposed to be, and you get the function. And this is what we do with these patients. The tricky one are the 7A, 7B, or the 6, because this one, they have a lot of mental component of it, so strong that whatever you try to do to bring it back, they'll fight you. They're essentially fighting what's supposed to be normal. So anyway, we try to explain to the patient exactly what Ben said. We're trying to produce with our test that function, and so that the scapula will function well.
Thank you very much. Giovanni, back to you, and Elena. Those are the main questions.
I want to add one
Thank
more
you so
thing.
much.
Just one second,
mi
because
sembra
there's
che
one
state
question.
dando dei messaggi eccezionali. La mia impressione
Thank you very much. My gut impression is to see a match between Nadal, Djokovic, and Federer. And who's winning is the audience, because this is really a great show. Now we have to go to sleep. You are in America and it's day here. There, it's night now here. So the last question with Elena Silvestri. One last question. A young athlete with the scapulothoracic dyskinesis without any symptoms. Are we going to treat dyskinesis or not? No symptoms.
Yes, this is a very common problem when we're talking about throwing athletes, baseball players, tennis players. There is a good body of literature that tells us that observable scapular dyskinesis with no symptoms, there's a 43% increased risk of them developing subsequent problems. Because remember, this is not a diagnosis, this is impairment. If they have this impaired position, as Bassam showed, impaired position, they can't do normal things. They may eventually break down with internal impingement or whatever. So in those situations, if they have this positive scapular assistance test, then I would very definitely put them on a program that has to do with integrated scapular positioning with arm motion. If they're not throwers, if they're just students, I wouldn't worry about it.
I want to there are two questions came in the chat. One question about whether the lower trapezius transfer affect the dynamic of, this is one of the chat. It does not, and this is not the topic of this presentation, but to the lower trapezius where you transfer it, it still has an impact on the whole scapulothoracic retraction that Ben Kibler was talking about. And when we put the electrode for the pec, is deep in the axilla, by the way. This is the only way you can sense the pec minor without sensing like the other muscle, because you cannot put it, the surface EMG, you put it here because you cannot detect the pec. The only way, you have to put it deep in the axilla to feel it.
Perfetto. Io penso che
Perfect. I think we want to thank you very much. We don't want to steal your time any longer. And of course, there will be further opportunities in the future. I'd like to thank Todd, Bassem, Ben, and with some of you, I will have the opportunity to meet you in Las Vegas during the American Academy. Thank you very much for spending time with us. You are really great. Thank you very much. Good night. Good night.